one of the pulmonary pathologists at Cleveland Clinic, and he's the author of what was the name of it?
Non-neoplastic.
Non-neoplastic.
Wow, that's really loud. Is it loud? It's all loud, yeah.
Non-neoplastic pulmonary pathology and algorithmic approach that by some of the comments I read, one of them was mentioning it's a masterpiece. It's a very good book that published May 16th. Do we have it here?
We don't have it here, but I'm going to give out little, they're sort of like business card kind of things, but they have the book information there, so anybody here who's interested can buy. I'll leave it at the clinic.
As of today, there are only 10 was left on Amazon. So if you want it, you should hurry up. So we're very pleased to have him here today to talk to us. He's a national board teacher, and he can teach very complicated pulmonary pathology in a very simple way for those of us that have trouble with pulmonary pathology. Recently, in community hospitals, they have started EBUS, and it's really hard to make a diagnosis with a small portion of the tissue they give us in EBUS pathology. But Dr. Mukhopadhyay, they're going to help us today to make sense of such a small pieces that we get. All right, welcome Dr. Mukhopadhyay today.
Thank you very much, Leila. Thank you guys. Thank you for having me. Most of all, thank you for spending your Sunday with me and spending your time here. I'd like to thank Leila especially for inviting me to this talk. Thank you so much for bearing with me and with all my demands and all that, but it's been really nice working with you. Thank you also to Kelsey for helping me out with all the setup. And thank you for the Colorado Society of Clinical Pathologists for having me here. It's really an honor. So we're going to do 3 talks, as you know. Each talk is going to have 3 take-home messages, and I hope that it's going to go really fast and might be a blur, but at least those 3 things should stick in your head. And in addition, what I'm going to do is I'm going to show you one image at the beginning of each talk, and I hope that that image will stick with you. And at least when you see that image back in your practice, you'll know, I know what this is. And I know what this is because I heard this in Vail, and Dr. Mukhopadhyay taught me one thing in a 60-minute talk. So this is the talk that we're going to do for the first hour. Small biopsies, big deal. Practical approach to lung cancer diagnosis in the era of EBUS, targeted therapies, and immunotherapy. So we're going to focus here on small lung biopsies. I'll talk about that in a second. I'm a staff pathologist at the Cleveland Clinic, and in my current practice, I used to be a general surgical pathologist in my past life. But in my current practice, which is for the past 5 years or so, I do exclusively thoracic pathology, which is kind of a oddball thing, and very few people have the luxury or the volume to do that. But I do now lung pathology, mediastinal pathology, pleural pathology. That's exclusively what I do in my current practice. I'm also the director of the frozen section service, so I get a lot of frozen section related questions and stuff too, but it's purely now lung pathology for me. I don't have any conflicts of interest to disclose, and this is our image of the talk. This is the image that we're going to go back to at the end, and hopefully we'll have learned something about this. So if I ask you, this patient is an adult, let's say 60 years old, with a lung mass. There's no history of anything else anywhere else. No history of cancer, no history of any other malignancy. He has a solitary lung mass. And what is this? Just take a second to think about it. What would you think? Would you think small cell carcinoma, non-small cell carcinoma, adenocarcinoma, squamous, large cell? Just think about what you would do in your own practice. Would you reach for the immunostains? Would you look up the history? Would you sign it out? Would you send it out? Think about it. And we'll come back again at the end to this. But this is really what I'm going to focus on for some part of the talk. So here are the 3 take-home messages. As opposed to most talks, I'm going to give you the take-home message right in the beginning and then re-stress it at the end. So there are 3 take-home messages. One, that many lung cancer cases can be diagnosed in small biopsies, things like transbronchial and needle biopsies, with 0 immunohistochemical stains. Absolutely nothing. Many, I'm not saying all, but many lung cancer cases you can do without, and I'll show you how. The second is there are cases that need immunohistochemical stains, and in that particular one, I want you to remember one fact, and that fact is about P40. This also applies to P63. That if a poorly differentiated non-small cell carcinoma in the lung, the kind that you need to subtype, if that is not strongly and diffusely positive for P40, it's not squamous cell carcinoma. It just cannot be. And I'll show you why I say that and how we back it up. And the third take-home message is that EBUS-TBNA, really the main thing that EBUS does is that it combines diagnosis and staging in lung cancer. In other words, you get to know what it is, and you get to know, at least for the mediastinum, what the stage is, and has largely replaced surgical mediastinal lymph node biopsies. And that's in my, when I was training, even in the beginning years when I was practicing, we saw a lot of mediastinal lymph node biopsies for staging. We'd get 4-hour, 2L, 2-hour, we'd get all those biopsies. That's kind of gone away. It's become rare to get one of those cases. That's because all that business has moved to our cytology colleagues. So let's talk about the first objective first, which is to create a plan to accurately diagnose and subtype lung cancer on small biopsy specimens while conserving tissue for molecular studies and PD-L1 testing. Now, you realize this is kind of opposite. So for one thing, which is accurate diagnosis, you need the more tissue, the better. And the other demand is that you have to conserve tissue and don't use up all that tissue. So you have two opposite demands. Somehow you have to reconcile these two and make an accurate diagnosis while still preserving tissue. How do we do that? I'm going to share with you my approach, how I do it in my practice. And the key here is doing more with less. So this is an article that I wrote for modern pathology just after we had given the long course in pulmonary pathology in 2011. And why this came out then is in 2011, the paradigm shifted from saying that H&E is the gold standard for lung cancer diagnosis to accepting that there are some cases where H&E is not enough. And in 2011 is where it shifted, the WHO gurus accepted that this is happening, and then we changed our protocol a little to accommodate immunohistochemical subtyping. What are small biopsies? Well, it's not just any biopsy that's small, it's biopsies that by definition have small pieces of tissue, and those biopsies are transbronchial biopsies, endobronchial biopsies, and CT-guided corneal biopsies. And of course, those two are bronchoscopic biopsies, and this is a peripherally CT-guided for a peripheral lung lesion. Now, these are not small biopsies, resections, so wedge biopsies, segmentectomies, lobectomies, those are obviously resections. And fine needle aspiration, although it is a kind of small biopsy in a sense, has a completely different set of issues that come with it. So I'm going to focus only on this group, small lung biopsies. So here's a bronchoscopic biopsy. This is the kind of piece that we get. These are very tiny pieces of tissue, typically obtained by a pulmonologist. And not all of these are EBUS. I mean, some of them are just conventional bronchoscopy specimens. And they look like that. So you get small pieces of tissue like that. So both transbronchial and endobronchial biopsies fall under this category. Then you've got CT-guided corneal biopsies, typically for a peripheral lung nodule or mass. Actually, it's always for some sort of a focal opacity or mass. So CT-guided corneal biopsies are never performed for anything else other than a focal lung lesion. So even just by seeing that needle-shaped piece of tissue, you know that the patient has a lung nodule or a lung mass. And that's the kind of needle-shaped piece of tissue that you get. So I'm going to talk about two sins that people have seen in my concert practice, people committing in subtyping lung cancers and approaching lung cancer. Two sins in lung pathology of this particular issue. First sin is doing immunohistochemistry when no immunohistochemistry is required. Absolutely nothing is required. Yet I get a tray a full tray. There's 7 different stains. There's probably like a vimentin mixed in there, and just ridiculous things. But even things that you would think are more reasonable, like a CK7 and 20 TTF and absent, are actually not required, and I'll show you why. So look at this case. So this is a small lung biopsy, it's probably a needle biopsy. And my process when I look at this particular image is almost entirely H&E guided. So my first thought is, this is abnormal. You guys agree with that? This is an abnormal. There's nothing normal about this. This is abnormal, that's all abnormal. The second decision I make, which is also purely on H&E, is that these are malignant cells. They're completely disoriented. There are no cilia on any of them. There's no, there's a lack of polarity. There are cells pouching into the air spaces like this in a micropapillary distribution. There's just no normal here. So this is a malignant proliferation. And the next question down the line is it malignant squamous or malignant gland forming? To my mind, this is obvious. The cells have intercellular mucin, they're forming lumens, and they're forming architectural patterns that are characteristic of adenocarcinoma. So I feel that the H&E alone tells you that this is glandular. Here's the high MAG of these cells. This is, again, clearly malignant and glandular. So I'm at adenocarcinoma already, just from the pure H&E. I don't need the history at this point. I don't need to know what the patient has. At this point, just to get to adenocarcinoma, I need nothing else. There's even a desmoplastic stroma that, if you were wondering if this is some kind of a bland benign thing, this is really as malignant as you can get. So the next step I take after this is not immunohistochemistry, it's not molecular. My process is, I look to see what the clinical information is. And what I'm looking for is there a history of a carcinoma elsewhere? And that is the key differentiator for what I do. So how do I find that? Well, I look in COPATH. Typically, we use COPATH. I look to see if there's anything else. We get a printout of all previous cases, as many of you probably do. I look to see, is there a history of something else? Is there a history of pancreatic cancer? Is there a history of breast cancer? Renal cell carcinoma? If there isn't, the next thing I want to know is there a history of that in our medical system? I realize many people don't have access to clinical information, but we easily do, so I just go into Epic and look to see if the patient has a prior diagnosis. So far, I haven't used a single immunohistochemical stain to do anything here. I've just used H&E and I've looked up clinical information. It would be really nice, and most of the time it is, that the patient has a solitary lung mass. So what you have here is, you have a solitary lung mass, you have no history of carcinoma elsewhere, and you have something that's clearly adenocarcinoma by H&E. What's the bottom line diagnosis? Now, many people try to do too much in this situation, and that's the mistake. All you have to do in this situation is just say adenocarcinoma, and that's the end of my diagnosis. And we're talking here about needle biopsies. I'm not talking about lobectomies or other things where you have to do more. It stops here. I don't say adenocarcinoma consistent with lung primary because, frankly, nobody's asking. It's a lung mass. There's no history. What else could it be? Now, clinicians sometimes, I've had in my, let's see, I started signing out in 2007, so how much is it, 10 years now? In 10 years, I've had 4 times a clinician ask them to say, why didn't you do the TTF1? And you know what I tell them? I said, why would I do it? Then there's a silence on the other side. They go, to prove that it's lung cancer? I'm like, what else would it be? Is there a history of something else? Most of the time the answer is no, and then you can just explain to them that TTF positivity is not going to prove that something is lung cancer. TTF negativity is not going to prove that something is not lung cancer. So what do you add from a patient that has a clinically classic lung cancer? What are you going to add to that? So let me just take you through that reasoning. So in this case, I signed it out exactly like this. I just called it adenocarcinoma, and I didn't do anything in terms of immunohistochemical stains. People are very uncomfortable with this. People want to put a TTF1 or a napsin or a CK7. How do we know this is not metastatic colon cancer or pancreatic cancer? So let's look at this. Should we have done this? I wouldn't do it. Should we have done this? Do we need TTF and P40 to subtype this case? We don't. We already know it's an adenocarcinoma. So TTF and P40 is meant for cases that you cannot subtype on an H&E, and that's when you need that protocol. Do we check history and radiology? Yes, I do. And my sympathies with those who don't have access to clinical information, and certainly you are working in a situation where you probably do need to do more, but when you have access to some history and radiology, there's no need to do anything else. And then after I sign out, do I send for molecular testing? Absolutely I do, and we'll go into that as well. Why not do immunohistochemistry? So as I pointed out to you, positivity for TTF and napsin does not necessarily prove lung cancer. So thyroid cancers, many of you know that they express TTF1, but very few people actually know that thyroid cancers also express napsin. So especially papillary and follicular thyroid carcinomas, co-expression of napsin and TTF1 is not uncommon in those. We've also, so recently I saw a case which was GYN primary and had TTF1 and napsin. Some of you might know from the literature that clear cell carcinomas of the ovary express napsin, and many other endometrial and ovarian cancers potentially can express TTF and napsin both. So really, having TTF positivity doesn't prove anything beyond what you already knew. The second issue is that when TTF, and this is the more important issue, that for a mucinous tumor like we just saw, chances are TTF will be negative, and then you're against that. And what I've seen people do is they do all their stains, and when the TTF is negative, they say clinical correlation is required. And you know what the clinical correlation is? They just ignore what they say. There's no clinical correlation. In other words, there's nothing that they need to do because there's no need to do anything else. There's no history of anything else. They will always do a PET for staging in lung cancer cases. And if the PET shows up something else, they'll come back to you and hey, there's a lesion in the pancreas. Can you look at this again? And that's a perfectly reasonable way to do it. But in the vast majority of cases, when you say in a patient with a lung mass, when you tell them TTF1 is negative, it changes nothing. That algorithm is in the mind of the pathologist, not in the mind of the clinician. And finally, it is extremely rare for a carcinoma of a non-pulmonary site to present as a lung mass, especially as a solitary lung mass, without a known diagnosis. So in other words, if you don't have a history of something elsewhere, and it presents as a solitary lung mass, and the patient actually has a met from the colon, that is extremely, extremely uncommon. So you could either chase the rare examples, or you could tune your practice towards more common and expected, and I prefer to do the latter. So with most patients with a history of a lung mass, and no history of cancer elsewhere, the site of origin is not even a question. So by doing the TTF and absent, we are actually trying to answer a question that the clinician is not even asking. So it's a waste of tissue. And finally, if you do all those stains and you put 1.5 trays of immunohistochemical stains on it, you are depleting the tissue. With every stain you do, you are depleting tissue for molecular testing, which is really important for the patient, as you all know. The results of molecular tests, especially in metastatic disease, are very, very important. And now PD-L1, as the previous speaker mentioned, is also a key thing that you need to think about. So I think I've beaten this point enough. What happens when TTF and absent are negative? It's still lung cancer. The patient will still get a PET scan, and most clinicians won't do anything differently. And I've spoken with my clinicians, even with the ones who call me asking about TTF1, will you do anything different? So what happens? Will you do a colonoscopy? Will you do whole body CT scans? None of that is going to happen. It's all in our minds. So this is a waste of time. Adenocarcinoma is still the correct diagnosis, even if there was a pancreatic primary somewhere else that the clinician didn't know about, and he comes back and tells you, the basic fact that this lesion is an adenocarcinoma is still correct. Alright, so now let's go to the next issue, is molecular testing. Now you'll find that every speaker that talks to you has a different set of molecular tests. That's because every institution has created their own protocol. So I'm going to share with you the protocol that we do. This changes all the time. Almost every 2 or 3 months something else comes up and then we have to add something or delete something. But our current protocol is this. So for non-squamous, non-small cell lung carcinomas, we do, I think we'll have to on the phone, if you can delete that, or maybe I can do it here. I wonder if the laptop needs to be plugged in. If the phone is fine, I think that's good, but I think the laptop is running out of power. Does this need to be plugged in, Kelsey?
Kelsey. What?
I think the laptop needs to be plugged in somehow. Alright, so let's take this as our opportunity for questions. Any questions so far, guys, on the stuff that I've talked about? Anyone?
Yeah, I have a question for you.
Yes, please.
So the first picture looked, obviously very adeno.
Yes.
The second picture, down on the bottom, there were a couple clusters that had more solid cytoplasm.
Yes.
And one thought that comes to my mind is, do you need to throw a P40 on to see if it's a mixed adenosquamous, or does it not matter in a small biopsy? How do you handle those?
That's a great question. So the question our colleague asked here is, so when you have a thing that's adenocarcinoma, like you saw in some of the original pictures, but then the subsequent, some areas of the tumor look a little bit more solid, do you need to do stains in those areas to figure out? So to figure out whether it's an adenosquamous or whether it has a squamous component. So my practical advice to you is, in something that looks like adenocarcinoma in the majority of the biopsy, chances are that the solid area is just a solid adenocarcinoma. In other words, it's the more poorly differentiated area of the same tumor. The second question, the second point comes to the thing you raised, does it matter? In terms of triaging, it doesn't matter. So whether you have an adenocarcinoma or an adenosquamous carcinoma, you're still going to triage it for molecular tests. So it doesn't matter whether it has a small squamous component. The time when you need to really worry about a squamous component is when the solid area also looks squamous, meaning that it has intercellular bridges or keratinization. Even then, if you miss a small squamous component, it has no clinical significance.
Are there
So-
any molecular tests that are being done routinely on squamous cancers?
That's a great question. The question is any molecular tests that are being done routinely on squamous cancers? The answer is no. So there are two exceptions to that. One is that patients who are never smokers and get squamous cell carcinomas, and that happens rarely, it's not common. So if you sign out a case of squamous cell carcinoma, you're sure it's squamous cell carcinoma, and then the clinician calls you and says, hey, this patient is a never smoker. Can you do your routine adenocarcinoma test on it? My approach is to say, yes, I'm happy to. And that's because squamous cell carcinomas in never smokers are likely to be an adenosquamous carcinoma that's partially sampled. And in that case, there is a possibility that that might be driven by some kind of a genome. So that's one. And the other thing is, I mean, this is not a molecular test, but PDL1 is done on squamous cell carcinoma. So, but no molecular tests currently that we're doing on squamous cell carcinoma, with the exception of that. That's a great question. Okay, so we do EGFR, KRAS, BRAF, and MET on all our non-squamous cases. Thank you for that. And then we do either by FISH or by immunohistochemistry, ALK, on our non-squamous non-small cell cases. And why I say by FISH or immunohistochemistry, what I mean is if we do it on our biopsies, we use immunohistochemistry as our first line test. But if we're doing it on cytology, we use FISH. And we go back and forth, and often we do, if immunohistochemistry is positive, we try to confirm it by FISH as well. But the point the previous speaker made about immunohistochemistry being actually a more clinically relevant test is actually true, that even if your FISH is negative and your immunohistochemistry is unequivocally positive, chances are your clinicians will treat that patient as an ALK positive case. So we use the ultrasensitive D5F3 antibody of ALK when we use immunohistochemistry, and that's really a great marker. And I've personally had cases where it's positive by ultrasensitive ALK immunohistochemistry, but negative by FISH, and yet the patient was treated as if he was ALK positive by clinician. So that immuno is a great one to have in your lab. Finally, we do on all our non-squamous cancers also ROS1 and RET, and you probably have heard about ROS1, but RET is an emerging marker too. These are relatively uncommon, so it's not a really big issue to miss them, but we still include them in our lab. And finally, we do PDL1 immunohistochemistry on all our cases. We are probably over-testing because we test all our cases regardless of whether they're metastatic or not, and much of that information is not useful, especially if it's a resectable small cancer, but we are slightly over-testing our population. So let me give you a few more examples of what I would call adenocarcinoma, and the case would be open and shut. I wouldn't do anything else. Here's an example. Beautiful glands and malignant cells. This one is gland formation, intraluminal mucin, malignant cells, nothing else is needed. Here's a slightly more difficult case here. Sometimes because the cells are more cuboidal, people have concerns about whether this could be reactive. But if you really look at the cytology and look at the junction with the surrounding lung, it becomes clear that this is malignant and gland forming. Again, I do nothing in cases like this. Here's a really bland example, and then the question shifts. The question becomes, is this benign or malignant? And that's a completely different talk, which I won't do. But once you have decided that this is malignant, you don't need to do anything else in terms of immunohistochemistry. Here's a slightly more difficult case. It's slightly solid, actually pretty solid in its architecture, but each cell you can see has intracytoplasmic mucin, kind of like a signature cell. And if you have that much intracytoplasmic mucin, there's no question about it that this is adenocarcinoma. Just to confirm to you. So no stains at all are required for some time. The same goes for squamous cell carcinoma, and I find people have much less problems with a flat-out easy squamous cell carcinoma, and there are no stains to do, so people generally don't do that. So this is what I would consider as just a slam-dunk squamous cell carcinoma with keratinization. In the old days, as far as 6 years ago, intercellular ridges would be considered a fairly robust criteria for squamous cell carcinoma. I have sort of given up on that because intercellular ridges can be hallucinated, they can be imagined, and it can get very subjective. You can have small spaces in adenocarcinoma that look very much like intercellular ridges. So the only thing that I consider slam dunk evidence of squamous cell carcinoma is clear-cut keratinization. Here's another example. I do nothing in a case like this. gets signed out and goes straight to PD-L1 immunohistochemistry. There's nothing else. So that's our first objective. When you have clear-cut evidence of adeno or squamous, please don't do anything else. There's no need to do it. So we come to objective number 2, describe what immunohistochemical stains are useful when you do need immunohistochemical markers in biopsies. Which brings us to sin number 2, which is not doing immunohistochemistry when immunohistochemistry is required. So now we're shifting gears. We are looking at cases now like this one. So this is a case that I recently looked at that was initially seen by an outside pathologist. And if you look at this carefully, just take a second to think what your gestalt is. And what this is. It's a lung cancer. There's a lung mass, and it's an adult patient. There's no tricks here. There's no history of anything else. So the only question is what kind of lung cancer. It's clearly not a small cell carcinoma, right? Everybody would be with me on that. It's non-small cell carcinoma. So our choices are here with every non-small cell carcinoma. Is it adeno? Is it squamous? Or is it unclassified? So my gestalt on this when I looked at it was squamous. I thought it kind of looked squamous, and all of us have those feelings, right? It kind of looks squamous. But the interesting thing is, what really is unquestionably squamous is actually this thing at the top of the surface epithelium, which is this thing over here. So this is unquestionably squamous, and in fact, some of it is unquestionably benign, as I'll show you in the next images. So the thing at the top left, on the top of the picture, is actually the surface squamous epithelium, and a lot of that is actually benign. But when you look at the malignant cells that are at the bottom, they seem to resemble that, right? This seems to resemble this. There seem to be gaps between the cells that look like intercellular bridges. It looks very squamous. Here's another example. Now you can clearly see the overlying epithelium is benign and squamous, so there's squamous metaplasia. And then this thing has to be a squamous carcinoma, right? Can I take a vote? Like how many people just have a feeling that this is squamous? Okay. Does anybody have a feeling that this is adeno? Does anyone see clear-cut, well-formed glands here? Anybody see mucin? So our 2 criteria for being absolutely sure that this is adenocarcinoma are not there. We don't have those. Does anyone see keratinization just flat out, like I showed you before? No. So this is a poorly differentiated non-small cell carcinoma that needs immunohistochemical stains for subtyping. It doesn't need immunohistochemical stains to tell it's lung cancer or not. That's not even my question. My question is it adeno or squamous? Now what happened is the outside pathologist chose not to do immunohistochemical stains, and based on the gestalt, which is very reasonable, he said non-small cell carcinoma favored poorly differentiated squamous cells. And we can all understand why they say that. It looks very squamoid. But here's my process here. I say it's abnormal, it's malignant, it's non-small cell, but I'm not sure of the subtype based purely on H&E. So this has exceeded my threshold of what I can comfortably diagnose on H&E alone. So I did a 2-marker panel. The first stain is P40, which you guys know is a marker of squamous cell carcinoma. Now I'll say again, if P40 is negative in a poorly differentiated non-small cell lung carcinoma, it ain't squamous. It's just not squamous cell carcinoma. So this, you can see a beautiful internal control here from the squamous epithelium that's above it. The stain clearly is working, and the tumor clearly is negative. So this is not squamous cell carcinoma. Here's another view of the same thing. Here's the TTF1 in this case, and it's blazingly strongly positive. So this is actually an example of a poorly differentiated adenocarcinoma. You can conceptualize this in your head as a solid or poorly differentiated adenocarcinoma, and that's really what this lesion is. It's a very squamoid looking adenocarcinoma of the lung, and this shows you why you do need immunohistochemical stains in the poorly differentiated examples. So here's the TTF, and you can see here that the overlying epithelium is negative as you would expect in squamous epithelium. So here's the summary. The P40 was negative, and the TTF1 was positive in this case. So this, my bottom line diagnosis was poorly differentiated adenocarcinoma. Now how the WHO likes to word it is, they are a little more wishy-washy about it, and there are reasons that I won't get into why they chose that terminology, but what they say is non-small cell carcinoma favor adenocarcinoma. I've never used that terminology, I just flat out call it adeno. In other words, even if you cannot call it adenocarcinoma by H&E, the immunostains make you call it adenocarcinoma, and that's why this is the appropriate diagnosis. Number of eyes used? 2. Not a full tray of immunostains by any means. This is just 2 immunohistochemical stains. Here's another example. This is what I presented at the lung course in 2011. A lung mass biopsy. Again, a solid sheet of cells. All you know is that this is malignant and it's not a small cell. But beyond that, it's very, very difficult to figure out what this is. Could there be intercellular bridges? This is going to be very difficult to figure out. Certainly, I wouldn't stick my neck out on just a few spaces like that. So I would subtype this. And in the old days, before we had P40, we had a 4-marker panel that we had developed, and that was TTF, napsin, P63, and CK56. This case is TTF and napsin positive, and therefore is a poorly differentiated adenocarcinoma, same as the previous case. Again, 4 markers used, and I've changed my practice since then, so now it's gone down to 2 markers, but you could basically do it with 4 markers even in the beginning. And the study I'm citing is the study that we did in 2011 that pretty much changed the paradigm of this non-small cell lung carcinoma classification. And what we showed with this, with using resections as a gold standard, is that this kind of subtyping is really accurate. And it took a lot of convincing for the WHO to change its mind and say, hey, even if you can't do it on morphology, that immunohistochemistry can give you the right diagnosis, can be reliable. But you have to follow some rules, and we'll go over those rules in a second. This study that came out in 2011 in the American Journal of Search Path is one of the highest cited studies in the world literature for non-small cell lung cancer subtyping, and is one of the highest cited also for napsin A as a marker in general. So I would strongly recommend, if you guys see lung cancers and you see poorly differentiated non-small cell, this is a paper you really should download and read. It's very useful. So we come back to this picture. Again, this picture I think is a non-small cell lung carcinoma that is not clearly classifiable on H&E. So I would not trust my morphology on this, and I would go to immunohistochemical stains. Here's the old panel, the 4-stain panel, TTF and napsin, strongly positive, P63 and CK56 negative. This is a poorly differentiated adenocarcinoma too. 4 immunohistochemical stains used. So let me take you now through a couple of things, because I'm sure as I talk about this, people say, well, what about carcinoid tumors? What about large cell neuroendocrine? What about melanoma? So let me just take you through the entire process that leads me to the conclusion that this is a non-small cell carcinoma and needs to be subtyped. All right, so let's go step by step. So my first thing that I need is it malignant? And that is a pure H&E based question. There's no immunohistochemistry that helps with that in the lung. So this is the first question I ask myself. Is it malignant? If it's no, it goes into a separate bin. If it is malignant, the next question I ask myself generally is it carcinoma? And in the lung, most malignant things are carcinoma. But remember, you can get exceptions. So you'll get sarcomas in the lung, you'll get melanoma, you'll get lymphoma. And the decision to do immunohistochemical stains to take you into that part of the flow chart is a purely morphological one. So you need to think by morphology, could this possibly be lymphoma or melanoma? And it's reasonable to do stains to rule that out. So then you need immunohistochemistry. Now once I've decided it's carcinoma, my next question is it primary or metastatic? So I ask myself that question even before I go down that route. And for that, I don't do immunohistochemical stains, I look at the history or radiology. And like I said before, if there's no history, I don't even consider a MET. So that's my process. I do not go down that line unless there is a history. Now if there is a history, then I try to figure out, well, is this a reasonable differential diagnosis? Does this have clear cell morphology? Should I be thinking of a MET from a renal cell carcinoma? Should I do stains? So that's a completely different part of the flowchart. If there isn't a history, I go into presumed lung primary. And at that point, I ask myself, small cell or non-small cell? And I find people make a lot of mistakes here because they don't even think of small cell, especially if it's a resection specimen or a core needle biopsy specimen, things where small cells are not usually seen. People don't even think about asking themselves that question. But you have to ask yourself that question even before coming into this final pathway, and that is non-small cell carcinoma. And then my next question is, can I easily subtype it on H&E? And as I showed you, there are cases that are very easily subtyped just on H&E, and if it is, then I do. And only if the answer is no to that do I go into immunohistochemistry for subtype. So is that clear, guys? There's a lot of H&E-based questions before you even come to the consideration of immunohistochemistry in lung cancer, and that's my process. So in a case like this, that looks clear cell, it's so clear cell, certainly I would think of metastatic RCC, but my first step would not be to throw stains on it, it would be to look at the history. Is there a known RCC? Is there a renal mass? Similarly, if I had a case like this, would I be thinking non-small cell lung carcinoma? Of course not. I think, is this a met from the colon? There's dirty necrosis, there's this pseudo-palisading or garland or whatever you call it. But there's a look that just looks colonic, and again, I'd go to history and look to see if there's a met from the colon. Again, I would not throw immunohistochemistry on this unless I knew that there was a history of colonic cancer. Now, a case like this looks reasonable for a poorly differentiated lung cancer, but I cannot subtype it on H&E. Adenocarcinoma, how many people? Squamous cell carcinoma, anybody? Anybody willing to call it on the H&E?
Malignant.
This malignant for sure. Yeah, that's a good call. Malignant is a good call. Non-small cell is a good call. But you need stains to figure this out. These are the results here. So this is actually a poorly differentiated squamous cell carcinoma with diffuse P63 and CK56 positivity and negative for TTF and NAPSID. So in the malignant cells, virtually all the malignant cells should stain with P63, and that's when you should accept it as convincing positivity. So in a case like that, my bottom line diagnosis would be poorly differentiated squamous cell carcinoma. Stains use 4, and in my current, I just use 2 stains for this, TTF and P4. How about this one? Again, I can't subtype this on H&E. And this is a poorly differentiated adenocarcinoma. But what do we do with that? So here's the key. And this is not uncommon if you use P63. It's less of an issue if you use P40. But with P63, a little bit of focal or patchy positivity is not at all uncommon in adenocarcinomas. Not at all uncommon. So what you need to know is 2 principles. First, TTF trumps P63. So if you have TTF and P63 both positive, it's an adenocarcinoma. Second, patchy P63 positivity is not a reliable marker of squamous differentiation. You just don't get focal staining in true squamous cell carcinomas. So what you do with that is just ignore it. Just ignore it. It doesn't mean that this is a focal squamous differentiation. If you had a true focal squamous component, it would look different, and that component would be diffusely P40 or P63 positive. So that's how you would know. This kind of patchy positivity means nothing. And so the bottom line on this is that focal P63 is not reliable for subtyping non-small cell.
Can you go back to the previous slide, please?
Sure, absolutely.
So, I just had an EBUS in the cell block. The P63 is the only thing that was positive, and it was about that strong, and everything else was negative. Is that enough to say it's a squam then?
Yeah, that's an interesting question. So if you had exactly that, I probably wouldn't consider that enough to classify. And so I would leave it unclassified, non-small cell NOS. But if you had just that staining but more cells, a few, like the same degree of positivity but all the cells were staining, I think that would be acceptable to call it squamous. So you really do need diffuse strong positivity, not this kind. But your point is well taken. If that's the only marker, do you trust it? So that's really where the question comes. What degree of positivity can you trust? Because remember, your H&E is out of the window. You have accepted that H&E cannot do it. So you're basing it solely on the immunohistochemical stain. So your threshold has to be really high for what to accept. So my answer to that would be strong and diffuse, and this wouldn't be enough. Alright, so focal P63 is not reliable. P63 and P40 are only reliable when they are strong and diffuse. We've talked about that. And focal P63 does not imply focal squamous differentiation. So what is the bottom line diagnosis here? Poorly differentiated diagnosis. So I just completely ignored the patch of P63 and don't do anything with that at all. Immunohistochemistry used, 4 stains. Now, people have some confusion between P63 and P40. It's not just that like P40 fell down from heaven with this profile of being a better marker. In fact, if you look at sensitivity, right? If you take 100 squamous cell carcinomas, how many will be marked by P63 and P40? It's identical. So they are both very good markers of squamous differentiation in terms of sensitivity. So they stain virtually 100% of squamous cell carcinomas, both of them. The issue is why P40 is better than P63 is a specificity issue. In other words, if you stain adenocarcinomas, like the example I just showed you, P63 will be positive in about a third of cases. Focal, patchy, true. So we knew how to deal with P63 even before P40 came along. But what happens is P40 does that far less often. So there's a lower proportion of adenocarcinomas that stain with P40. So this thing of having to deal with two positive markers is less. That's why people prefer P40 over P63. But remember, you will have that issue once in a while with P40 too. It's not a perfect stain. So here's an example of a poorly differentiated non-small cell carcinoma. Here's another one where I couldn't subtype it on H&E because there were no glands or mucin, no keratinization. This is a TTF1 stain, so this is a poorly differentiated adenocarcinoma. Here's the P63. So I would ignore this. This is not strong and diffuse, plus the TTF trumps the P63. Now watch what happens if I use the P40 on the same case. It basically goes away. So this is the advantage of the P40 over the P63, that in terms of staining adenocarcinomas, there is less non-specific staining than there is with P63. So if you had to pick one marker, I would pick the P40. I've seen people using both P63 and P40, and that's just a waste of a section. If you want to pick, just pick one and stick with it. But then if you have P63 and that's the only one you can use, there's nothing wrong with that. You just need to know how to use it. So the bottom line diagnosis in the case I just showed, poorly differentiated adenocarcinoma, immunohistochemical stains used. So one last issue before we leave the topic of subtyping, and that is, in a small lung biopsy, what is the appropriate diagnosis for a non-small cell carcinoma that is not clearly glandular or squamous on H&E? What is the appropriate topic? So my first advice to you is do not give it a name, so that poorly differentiated thing that needs subtyping. So please try to do immunohistochemical stains to subtype it. Don't give it a name before you've subtyped it and sign it out. And you'd really just need only two stains, TTF and P40. If it's still not classifiable, so what do we call these things in biopsies if TTF is negative and P40 is negative? Or like the question our colleague asked there, if there's P63 but it's not diffuse and you want to ignore it, what do you call that? What we call it is poorly differentiated non-small cell carcinoma. So this poorly differentiated non-small cell carcinoma, we gave it a shot on immunohistochemistry. It didn't work, so we call it poorly differentiated non-small cell carcinoma. Or you could give it the WHO name, which is non-small cell carcinoma, NOS. What you're saying is that we don't know what subtype of non-small cell this is. Some of these turn out to be unclassifiable even on resection, and a small proportion of these turn out to be adenocarcinomas on resection. But for clinical purposes, this diagnosis is enough. Now some of you might be saying, why not call it large cell carcinoma? It's like the third type of non-small cell carcinoma. That is more of a terminology issue than a morphology issue. And the terminology issue is here, is that large cell carcinoma is by definition, this is a resection diagnosis. So you need to have a resected sample. You need to have a lobectomy or a wedge. The entire nodule has to be out. And the idea behind that is that there might be some keratinization or glands that you might find on the resection specimen that weren't on the biopsy. So do not diagnose large cell carcinoma on any small biopsy, period. No small biopsy. FNA, transbronchial, endobronchial, CT-guided, you just can't make that diagnosis. So the criteria for large cell carcinoma in the lung are, first, it has to be a resected tumor. Second, it has to be a primary non-small cell. It's not, it's not a met from the breast or from the kidney. It has to be unclassifiable on H&E. Then you do your immunohistochemical stains, and it's unclassifiable. So it's just a non-small cell that you don't have a name for. You call it large cell. It's not a discrete entity beyond that. And one last thing, if TTF and P40 are negative, like in this case, this was a real case I had a couple of months ago that was poorly differentiated. It was reasonable to think of non-small cell in the differential. And on the rapid on-site evaluation, our cytologist called it poorly differentiated non-small cell carcinoma. And then signed it out as poorly differentiated non-small cell carcinoma on the corresponding cytology. And to my eye, it just looked a little bit more discohesive. This is not the best picture of the tumor, but there were other areas where the tumor was just not cohesive enough to be the classic picture of a carcinoma. So I considered other things, and I gave it 1 or 2 other stains. Here's a CD3 which is completely negative, and here's a CD20. This is actually a diffuse large B-cell lymphoma that wasn't even considered. So here's my practical advice to you. If you are trying to subtype what you think is a non-small cell carcinoma, and TTF and P40 are negative, stop. Step back and ask yourself, am I sure that this is carcinoma? Could it be something else? Could it be melanoma, lymphoma? And then you can approach it this way. First, you can ask yourself the morphologic question. Sometimes you'll be sure, and you don't need to do anything else. Sometimes all you need is a pancytokine. Just make sure that it's carcinoma and you're done. If it's more, if the morphology is suggesting melanoma or lymphoma, you can do other things for sure. So here are other tips for non-small cell subtyping. I'm not going to go through all of them, but they are in your handouts. But they cover things that I've already covered during this talk. Minimize immunohistochemistry, conserve tissue for molecular and PD-L1. TTF1 and P40 are enough for most things. Very, very important. So let me stress this point. When you go back home, if you're doing lung cancer cases, check your clone. Check to make sure your clone is 8G7G3/1. This is the specific clone that the literature is largely based on, that our paper was based on, and this is the clone that is, when TTF is positive, it's specific for adenocarcinoma. Now, if your clone is SPT24, go back home and check. If your clone is of TTF1 is SPT24 or anything else, there's another clone that's recently become popular in Europe and Australia. Those are not specific. They will also stain squamous cell carcinomas. They also stain mesotheliomas. They are creating havoc, as far as I'm concerned, in the subtyping issue because they are not specific. So you need to be sure that your clone is the specific one, because all the subtyping is based on the specificity of this clone.
Should the text then read that and show that your TTF
You have
is
type on the slide.
Yes.
instead of is?
Oh, I'm sorry. Yes, absolutely. Yeah. Thank you for pointing that out. Yes, I didn't catch that. Yes, exactly. I'm sorry about that. This is a typo. Ensure that your TTF is 8G7G3/1. Ensure that is not SPT24 or the other. Yes, please.
So Authority QC, which does sort of objective review of clones like this clone performs very poorly under Authority QC scrutiny.
Yeah, so there's an interesting, there's a good point. So there is a paper, I think it's from Australia, or it's somewhere that some kind of a QC study looked at TTF1 against the other clones. And what they found in that one study, and remember there are literally hundreds of studies on subtyping before this came along, from 2011 to this. This is a paper from last year. This study looked at the sensitivity of the 8G7G3/1 versus SPT24 and the other clone whose name I forget. So those clones are slightly more sensitive than TTF1 for adenocarcinomas. So what that does is, it stains a greater proportion of adenocarcinomas, and so to increase the sensitivity, they have settled for a marker that is really compromising specificity. And in my book, that's a bigger error. So if you have a TTF1 clone that stains mesotheliomas, that stains squamous cell carcinomas, you are not going to be able to perform your subtyping and these functions. So the only function in which it outperforms G7G3/1, if you're using the other clones, is in sensitivity for adenocarcinomas. And in my book, that's really not the critical issue here. In my book, subtyping is really the main problem, and it's creating problems. You'll see people have posted publicly on Twitter cases of lung cancer that are clearly adenocarcinoma, clearly squamous cell carcinoma, but are showing TTF1 positivity by the non-specific clone. And then when you switch it to 8G7G3/1, the TTF positivity disappears, and it's only P63 positive. So the clone really matters, and I feel that the paper that is the Nordic QC or whatever that the consortium was, is trading specificity for sensitivity, and they're making a big mistake there in terms of patient care. So that's why I use the G7G3/1. There's a similar issue with napsin. So again, when you go home, make sure your napsin is monoclonal, not polyclonal. Because polyclonal napsin, and we have published this, and Natasha Reckman from Memorial Sloan Kettering has published this too, is polyclonal napsin will sometimes stain GI tract cancers. And that makes its specificity lower. So if you're trying to tell lung versus GI and using napsin for that, you better have the monoclonal napsin. That's much better. So we use the monoclonal napsin and 8G7G3/1. This we've talked about, you have to make sure that you're not dealing with a lymphoma or small cell before you subtype. The subtyping panel doesn't help you to tell whether it's benign or malignant. Never diagnose large cell carcinoma in a small biopsy. And if both stains are negative, step back and reevaluate. Focal P63 staining is not a reliable marker of squamous cell. P40 is better than P63, but because of specificity, not sensitivity. Focal P40 or P63 you can ignore, and there's no rationale for using both stains. Just pick one and stick with it. Alright, so we come to our third objective, which is discussing why EBUS is helpful in lung cancer diagnosis and staging. So EBUS is endobronchial ultrasound-guided transbronchial needle aspirin. And just to make that simple to understand, bronchoscopists have traditionally put in a bronchoscope, through the airways and gone blindly and biopsied a lesion where they think the lesion is. Now they have ultrasound guidance to do that. And the ultrasound guidance has made it so that it's easier to biopsy certain mediastinal lymph node locations and to be sure that your needle is in the location. So there are lots of technical advantages that the ultrasound guidance improves the transbronchial needle aspirate performance. And there are studies that have shown that transbronchial needle aspirate staging of mediastinal lymph nodes is almost equivalent to mediastinoscopic surgical biopsies of those lymph nodes. So it increases the accuracy and the yield of transbronchial needle aspiration, especially for mediastinal lymph nodes, which are key in lung cancer. The accuracy is comparable to surgical biopsies of mediastinal lymph nodes, which were formerly the gold standard. Who undergoes EBUS-TBNA? In general, the mass needs to be central and has to have some indication of mediastinal lymphadenopathy. Large mass, central mass, mediastinal adenopathy, those patients undergo EBUS-TBNA. If you have a metastasis to the brain or the skin and that's accessible and you can biopsy that, you probably don't need an EBUS. If you have a peripheral lung lesion that can't be reached by EBUS, you're not going to be doing EBUS on that. If you have a small ground glass opacity, EBUS is probably not needed. But central lesions, EBUS is becoming really the first line investigation here. And what it's changed is that instead of doing a diagnostic procedure for the lung nodule and then a separate diagnostic procedure for the mediastinal nodes, now it's combined so that the lung nodule and the mediastinal nodes are biopsied in the same setting and can give you diagnostic tissue. Far fewer patients now need surgery for mediastinal lymph node staging, and diagnosis and staging are done in one procedure. So the bronchoscopist goes in with the needle, biopsies the lung mass, biopsies the mediastinal nodes, and you have diagnosis and staging in the same procedure. So for us, the important question has been in the past couple of years, can you do molecular testing on these samples? And the answer in brief is yes, you can do molecular testing on EBUS-derived samples. The next question is rapid on-site evaluation, meaning that the cytologist is right there telling you whether something is adequate or not. Do you need it or not? There's been a lot of debate about this. I'm not going to sort it out in one short talk. The answer is that there are advantages. Okay? If you have a cytopathologist on site, they can tell you that yes, you've got the lesion, it's malignant. Second, they can say, well, this is probably a carcinoma, can you give me a few more passes for molecular? Or they can say, well, I suspect lymphoma, can you give me more for flow cytometry? That's what we do at our institution. But we have a ton of cytopathologists doing this all the time. So there's a lot of issues in terms of time, cost, and personnel. So places where there's only one or two cytopathologists, this is going to be a practical issue to provide rapid on-site evaluation. So there's no easy answer. If you can do it, it's definitely an advantage, but there are practical issues. So I'm going to show you what we do with our cytology samples. So when the needle is withdrawn from the bronchoscope, we put it onto the slide, smear it. So you have two slides. One gets a diff quick, the other gets a pap. The pap gets read later. So the diff quick is read on-site and we give a rapid on-site evaluation. We try to go as far as we can. I'm not a cytopathologist, but the rest of, we have a huge cytopathology department that follows this uniform approach. Now what we do with the remainder of the sample is kind of unique to our institution, is that we put it into the cytolite solution, and this cytolite solution is used both for the cell block and for molecular testing. So this gets centrifuged into a little cell pellet, like go to the next, and this cell pellet then is used to make a cell block, and all immunohistochemistry that's required is done on the cell block. But the cell pellet is also used to make a thin prep slide which gives you adequacy for your subsequent fish. And then that cell pellet is also used for all our next generation sequencing. Now this is relatively recent. The fact that you can do next generation sequencing and EGFR, KRAS, BRAF on cytology samples is a relatively recent development, but our department has published a lot on this, and we have shown that this is actually feasible to do NGS on EBUS-derived cytology specimens. So this is a very long flowchart that this is going to come out in the archives of pathology and lab medicine, but I'm just going to summarize what happens in our department. So for every EBUS case, or many EBUS cases, the sample gets sent to cytology and gets handled like I just described, but a concurrent sample also gets sent to the surgical pathologist, which is me. So I get the biopsy and the cytologist gets the cytology specimen. And between the two of us, we decide who gets to test. And generally, the cytology sample gets tested first. If that sample is inadequate, then it goes to surgical, and then the surgical biopsy gets tested next. So that's we coordinate between the cytopathologist and the surgical pathologist, and the exact way in which we do this is outlined in this flowchart, which is in your handout too. So I'll cycle back to our first picture. When you see a case like this is a poorly differentiated non-small cell carcinoma that does need immunohistochemical stains for subtyping. Only really 2 stains are needed, and please do that and try to subtype. We come back to the last 3, the take-home points. Many cancers can be diagnosed in small biopsies without IHC. I hope I've convinced you of that. If you do have a poorly differentiated non-small cell carcinoma that's not strongly and diffusely positive for P40 or P63, it's not squamous cell carcinoma. And finally, EBUS-TBNA is now combining both diagnosis and staging of lung cancers. Thanks for your attention. Questions, please.
I didn't see the evidence for your second point. It sounds semantic to me.
The P40? Yes. So actually there is, yes, that's a very good question. The question about whether P63 and P40 proves, focal P63 or P40 proves a squamous cell carcinoma or not. Is that real? Does it have evidence? Or is it just a semantic question? So I'll point you back to the paper I referred, the 2011 AJSP paper. So in that paper, we specifically looked at this question, and how that was designed was, so we looked at a small biopsy sample, and we did all our immunohistochemistry on that. So we had some cases that had TTF and P63 both, right? And we didn't know what it was going to turn out to be on resection. But then we looked at the resection sample. So all of these cases had a subsequent resection. And all those cases with TTF and focal P63 turned out to be adenocarcinomas and did not have a squamous cell carcinoma component on resection. So in lung cancer, in the lung cancer subtyping realm, the resection is always considered to be the gold standard. So in that study, we had a gold standard, and these cases with focal P63, P40 did not have a squamous component. Now that finding that focal P63 occurs in adeno has been replicated by other people too.
That's not the question.
Yes, yeah,
That's
go.
not the question.
Yeah.
The question I'm saying is, prove to me that a P40 negative, TTF1 negative cancer is not squamous.
Yes, so so this is the second question, is that can you have a P40 negative squamous cell carcinoma? There is evidence for that too. So there's Natasha Reckman and Bill Travis did a large study in modern pathology where they looked at squamous cell carcinomas that were all resected, and then they did subtyping using the panel. There's not a single squamous cell carcinoma either in their study or in our study, not a single one that is P40 negative in either series, and others have done subsequently similar things. So you can go back to the literature and look at any subtyping study from 2011 onwards. There's not a single case that is completely negative for P63 or P40. So it's not just ours, and our study shows the same thing. It's the accumulated evidence over the years that has shown with multiple studies that just does not happen. Now the reverse, so you can have an adenocarcinoma that's TTF negative, we know that. But you cannot have a squamous cell carcinoma that's P40 negative, and the evidence comes from having subsequent resections that show that it does not happen. I take your point. I mean, this in the past when H&E was king, and we said, I don't care what the immunohistochemistry was. This was the dictum, I don't care what you could have TTF positivity, you could have anything, but that paradigm has shifted, and that's why I mentioned this. So what I would do is, if you think something is strongly squamous on morphology, but the P40 is negative, I would let the immunohistochemistry dictate your diagnosis there. It's such a strong strong finding the P40 positive. But it's a great question. Thank you.
For those other two, you showed the renal cell carcinoma, or what looked like renal cell,
Yes.
what looked like colon, but they don't have any imaging. They don't have any evidence of disease elsewhere on imaging.
Right.
I think you were saying you might sign that out as adenocarcinoma. Do you put a comment in? I mean, I'm sure at Cleveland Clinic you have the opportunity every day to be a
Yes.
hero. That's something, though, that we don't get to do very often, so it's tempting to throw
Yes.
the stains on there and
Yes.
say, hey, this might be a renal cell,
Yes.
and then they look and they're like, you're right, it was
Yes.
maybe they don't care, maybe
That's
we're
a
only
great- no,
heroes in
no.
our own minds.
Yes.
But do you at least comment that it could be
Yes.
one of these others? And
You're
don't
absolutely
stain?
right. You're absolutely right. So, if the morphology is as striking as it was there, so the two cases I showed, the renal cell carcinoma and the colonic, if the morphology is that compelling, I think you're not wrong to do a TTF and a PAC-8. That's all you need to do to figure that out. If the second case that looked colonic, all you need is really a TTF and a CDX2. So that's not unreasonable. My point is something that doesn't have the classic morphology of a colonic or a renal cancer. That's the point where you shouldn't be throwing immunostains. Yes, and even if I didn't have a history, I might throw the one additional stain on it in those cases. Your point is well taken.
What is your preferred panel for small cell?
Yes, that's a great question. So what is the preferred panel for small cell? Now, different lung pathologists have different approaches. Some don't do any immunohistochemistry for small cell. I do. So my preferred immunohistochemical panel, when I think something is small cell carcinoma, I do a pancytokeratin, I do a TTF and P40. What I'm trying to make sure is that it's not a poorly differentiated squamous. With the pankeratin, I'm trying to make sure it's at least carcinoma, that I'm not missing a lymphoma. And then I do a synaptophysin and chromogram, realizing that not all of them will be positive for synapto and chromo. I don't do a CD56 because although that's very sensitive, it's the same issue with with those sensitive TTF clones. It's so sensitive that it loses its meaning. It becomes non-specific. So CD56 positivity is well described in non-small cell carcinomas of various types, so I don't use that. So my panel is pancytokeratin, TTF, P40, synaptophysin chromogram. Please.
Small biopsy that is adenocarcinoma, further specify the hepatic pattern.
Great question. So the question is, in a small biopsy, it's adenocarcinoma. Do you need to specify the pattern? Is it lipidic or acinar or micropapillary? You could. So in our institution, the value of providing the pattern on a small biopsy is 0 because they all get managed the same way. So lipidics get managed the same way as micropapillary, as solid or acinar. So I don't waste my time doing that. You could do that. There's nothing wrong with providing the patterns, because they all eventually will get will get treated like an adenocarcinoma. Now, the argument for providing patterns come from places that might treat a lipidic predominant cancer differently. Like, for example, they might treat it with a wedge resection. The problem is, on a small biopsy, you don't know that it's lipidic predominant. You only know that the part you got is lipidic. So I really don't think that small biopsy, that the pattern gives you any useful information beyond what you already have from adenocarcinoma. So I just sign them up as adenocarcinomas. Good question. Anyone else?
Fine point, you
Yes,
mentioned that if
please.
you get a percutaneous CT-guided core biopsy,
Yes.
then there must be a lung mass.
Yes.
It's not actually true, because I had a case that ended up being a lawsuit because they did that with the ground glass infiltrate, and they got a very atypical looking, is it adenocarcinoma or not?
Right.
And so we said, well, it could be adenocarcinoma, do a wedge biopsy.
Was it localized? There was only one gram class of acid?
Yes.
Yes, so that's the point I'm trying to make. It's a localized lesion.
Localized.
Not necessarily a mass. What I'm saying is, if you get a needle biopsy of a lesion from the lung, you can be sure that there's something localized that they're going for. Nodule, an opacity, whatever you want to call
My
it.
point is, make sure
Yes.
there's a mass before you call it adenocarcinoma.
Yes, that's a
not
good
just a
point.
ground glass infiltrate.
Your point is well taken. Yes. That's
Very
good.
happy when that, and then
Yes.
what happened was the surgeon went in, there was no mass, so he said, well, I can't feel the mass, I'm gonna do a lobectomy. He does a lobectomy and there's no cancer.
Yes. Your point is well taken. Questions? Anybody else? The questions are great. I mean, they're just all extremely relevant. Anybody else? All right. Thank you for your attention. Thanks, guys.